Lori. Roy, Merle, nice to see you guys. I'm envious of your bookshelf, Roy.
There you are.
Hey, Merle.
How are you?
I'm well, thank you. How are you?
We're good. We're just, we're here.
Merle, I think that if we had like a passport that you got stamped for every like virtual online class session that you could come to, I think that you and Roy might be fighting it out for who gets the most stamps. But
we can share.
Right?
Here's my philosophy. I belong to the temple, but I'm not there this summer, obviously. And I can't do all the things I want to do. And I am so grateful that you're having all these programs because I can stay connected and I'm getting something from it. And I'm not just sitting here climbing the walls.
Absolutely. I think I know that you're not alone in those sentiments. And I will tell you just from the flip side of it, that, I think I'll speak for myself, but I could probably speak for all the clergy and staff too, that the opportunity for us to get to still engage with all of you, and that nurtures us and makes us feel less kind of isolated and marooned at home, as it were.
Well, and
is also meaningful.
I have a hard time understanding why the congregations here, and there's enough of them, aren't really doing anything. I mean, they're doing Friday night, Saturday morning, Torah study, but they're not reaching out anywhere past their normal programming. And it's frustrating, but what do you do?
I think what's hard, and we're struggling with it too, is to think beyond the normal programming, because so much of what's normal programming, for lack of a better way to say it, it kind of just makes bad TV, right? And I would include services in that, right? We finally figured out, I think, I don't know, going on 6 weeks ago, maybe, that just trying to do what we do in the chapel at the Irmis campus on a Friday night on Zoom, isn't meaningful and doesn't work. And that we have to create an experience that is unique to this medium and that uses this medium in a way to engage people in a different way than we would if we were sitting in person. And I think it's the same thing with learning opportunities and all sorts of things, that we can do things that we ordinarily wouldn't be able to do. Right. Navid's office happens to be across the street, so I could probably get him to come over and do this, but there's other folks who aren't, right? And so the opportunity, all sorts of different ways, right? I was saying to someone the other day, and that, I led a Shiva minion that on the one hand, on Zoom, that on the one hand, was a little bit sad beyond the reason the Shiva is always sad, but a little bit sad because here this family was sitting by themselves in their living room and not surrounded by, too much deli and too many people. But at the same time, there were 70 maybe people in the Shiva. Half of them, they were all over the country. And under normal circumstances, they would never all be gathered together in the living room.
Well, and a few weeks ago, Mari did her first Zoom funeral, and the family was in the sanctuary at Temple, and there were only like 5 of them. But there were for the Shiva, for both nights that they did it, there were people from all over the world. And there were people that adjusted their time frame, say in Israel, so that they could be on the Zoom Shiva at our time of day. And that too, I think that in a lot of cases, I see people that I never see at Shabbat services. And I'm not good at going out at night anymore. I mean, I've had a long day, whatever I do with the kids, with the girls for Sharon. And at nighttime, it's like, I don't want to go back out. So I've been doing it for ages, but there are a lot of people that have never done it before that are doing it now. So I think that's important too. It's a whole mixed bag of what we're going through.
It's a whole mixed bag. I was in a meeting last week having a conversation about, what are the things that at some point when this is all in the rearview mirror, what of this experience and that we've learned do we hope remains? And I said that, that we ought not to look at in-person events, in-person attendance versus Zoom or streaming as a zero-sum game.
Exactly.
Right? Because the ability for people to participate and engage who otherwise couldn't should still be afforded, right?
Right.
And to be able to make so much more of what we do, not just services, accessible.
Right. I mean, we're going to Sedona in a couple of weeks, just the two of us for the week. The kids are going on a motorhome trip with another family, and
I think Sedona wins.
So yeah, I do too. So it's a different four walls, but I know that if I can, if we have internet of any value, I can be someplace and I can get this or other stuff.
Absolutely.
So
not to mention, it's just like HBO, it's all on demand after, if you can't do it live.
Yeah, well, it all shows up on YouTube the next day. So
I know. It's gonna live forever. It's gonna live forever.
You're there forever. You're stuck with us.
Shifting gears a little bit.
Right.
I'm going to introduce my buddy Navid in a few minutes, but there are a lot of things that make the KHEIR Center unique. But this model that we have that relies almost exclusively on collaborators, on other expert organizations to provide services. It's something that came about very early on when I realized that, Rabbi Leader used to say that we didn't run singles dating programs at the temple because we couldn't do it better than JDate. And I sort of took that when we were first really kind of conceptualizing the KHEIR Center and say, like, I'm not going to run a legal clinic better than Beit Tzedek or better than Public Counsel or any of the other amazing legal service providers in the city, right? We're not going to be able to run a literacy program better than the Book Foundation, or we're not going to be able to do, mental health better than our house or better than Southern California Council, right? So how can we find the best providers in the city that are already doing this work? Right. And instead of reinventing the wheel, try to bring them, to KHEIR, bring them to the temple and help support the work they're doing in the community and make it easier for them to do it and remove some of the hurdles and barriers. And that this model really came from the idea that we couldn't do it alone, that we shouldn't do it alone, that we can't do it all. We're all by ourselves. And now, a couple of years in, we're up to nearly 30 collaborating organizations, right, who come into our space on a semi-regular basis to provide services to our clients. But the very first collaborator we had was KHEIR, was the KHEIR clinic across the street. And it was about 8 years ago. And the whole idea of the KHEIR Center was sort of just, germinating in my head and the heads of a few others. And I was trying to meet different folks and figure out who might, be interested in helping and providing services. And Doug Lynn, one of our associate executive directors, Doug Lynn, came into my office and he said, "Hey, you're working on this like social service center thing. Have you talked to the people at the healthcare clinic across the street?" And I said, the what? What are you talking about? He said, I don't know. I pulled out of the parking lot though, and I saw this big sign on the corner. It says KHEIR, like Paper Foundation, Korean Health Community, clinic. He said, have you talked to them? I said, what are you talking about? So I literally walked out into the parking lot, stood on the corner, and lo and behold, 50 feet away from the property, there's this big sign that I'd never seen before and a phone number. I pulled up my phone. I called the phone number. I said, "Hi, I'm a rabbi. I work across the street at Boulevard Temple. Can I come over and, learn a little bit more about who you guys and what you do and who you are?" And I got to meet with some lovely folks at KHEIR. And over the years, that relationship grew and turned into, KHEIR being one of the deepest and most robust collaborations that we have. They're the only provider we have on site that is full-time. And they're an amazing organization, a federally qualified healthcare center that Navid's going to tell us more about in a minute, what that means. And they're on site providing dental care and vision care. And their work at KHEIR, though, while, in many ways, one of the cornerstones of our service offering, is one small part of remarkable work that they do, all throughout the greater Koreatown. And I think the footprint's expanded a little bit beyond that these days. And the work that they do is so important, and even more so in this kind of, space of a global pandemic, because those obviously in the healthcare world are on the front lines. Before everybody jumped on the call, Navid and I were talking about the fact that he's sitting in his office and has been throughout this entire thing because they've been open seeing patients every day. So without further ado, my friend Navid, who is the Director of Patient Services, is that your title?
Yep.
Director of Patient Services at KHEIR Clinic. You've been there, what, 5 years?
5 years, yeah.
5 years.
Good.
I think you started right before we opened.
That is correct.
Maybe like 6 months or something before we opened.
Something like that, yeah. It was right about when we were starting things up, so.
We were also chatting about our mutual affinity for Cassell's, but that neither of our cardiologists approve of eating there too often. So, Navid, thank you for making the time to be with us.
My pleasure.
Maybe let's just start with kind of the Google Earth kind of global view of what is KHEIR, what is, it's just kind of smattering of the services you guys offer, and maybe for some of us also to throw even more into the question, what is a federally qualified healthcare?
Sure. Well, first and foremost, thank you for the gracious introduction, Rabbi. We appreciate that. And thank you all for allowing me to be a part of the meeting today. Appreciate being a part of this. So thank you. Again, I'm Navid Papehn. I'm the director at KHEIR. And as the Rabbi mentioned, we've been working very closely with one another for the last 5 years. And initially, really kind of approached this as a marriage more than anything, given the extent of our work there and the time that we intend to be here at KHEIR. So in any case, to kind of just answer the Rabbi's question, we are federally qualified health center, and essentially what that means is we're a safety net clinic for the underserved and uninsured individuals of Los Angeles County. Now we are specifically located in Koreatown, but Koreatown is also one of the most densely populated areas in Los Angeles. So there's quite a few individuals here in our area that either have limited insurance coverage or health coverage or have no health coverage. So our role is to essentially capture these individuals and bring them in for healthcare services so that whatever issues they may be dealing with don't get so far gone that they can't come back from that. We do a lot of work in regards to educating the public, outreach, doing enrollments into various state programs to provide these individuals with health coverage. And then of course we provide the services to them as well. So we've been around since 1986, but we've been a clinic providing healthcare services, I want to say since 2004, if I'm not mistaken. It was way before my time at KHEIR, but nevertheless, we are now a multi-clinic site, one of which is our specialty suite at KHEIR, but we also have our flagship clinic across the street from the Wilshire Boulevard Temple, and we have another clinic here on Wilshire in New Hampshire. And so it's been good. We have been open throughout this whole pandemic, so that's been nice for the people we work with, as well as for the people who need our services. And people have been coming in, so it's been an interesting experience.
So, still on mute. So you guys have been open, obviously, throughout all this. Now, your clients come in, right? Like I would go to my doctor for any kind of primary care, right, needs, or even maybe some specialty needs. So you said clients are still coming in, even for like routine stuff?
Yeah, so initially when this whole pandemic started, we were seeing a higher number of remote visits. So one of the good things that the state and the federal government did as a response to the pandemic was to allow for us to do telehealth and telephonic visits. So that's over the telephone or webcam. Prior to the pandemic, those all existed, but they weren't well structured. It wasn't promoted very well. And the reimbursement for those types of services was either non-existent or extremely low. So it wasn't financially practical for clinics like ours or any real practitioner to be able to provide that. Of course, with the pandemic, that changed, which has been a wonderful and surprising addition to what we're able to do. So we shifted quite quickly to doing remote visits. Initially, I think about 70% remote, 30% face-to-face. So some visits and some types of services we have to do face-to-face. They just, we can't do that over the phone or over video because we need to see the patient. But it was about a 70-30 split. As time has progressed, that's kind of evened out a little bit more. So we're looking at closer to a 50-50 split at this point.
So I want to go back to in a way, the reimbursement question without getting too into the finance. Just it's personally interesting to me because I think it gets to some of the structural barriers and in terms of the way in which care is delivered and what kind of care is incentivized and not based on a provider, and also in terms of the clients coming in the door, right? Because I think people think about free clinics, right? Like right, Saban had to finally change their name, right? Because it's not a free clinic. So COVID aside, the sort of not the business model, right? But people say, oh, is it a free clinic? So it is, in many cases, correct me if I'm wrong, free to the patient, right?
Correct.
If they are enrolled, in a program. Sure. But that doesn't mean that. But it doesn't mean that you guys aren't generating revenue.
Correct. Yeah. So we're not technically what you would consider a free clinic, if you're looking at the exact definition of that. But the patients that we see,
very few still around.
They're not a lot. There is one. It's there's Sunset Free Clinic here in Hollywood, and then I know that there's one out in Simi Valley. I think there might be one. They're there. They exist, but they solely depend on funding, donations, that type of thing. Right. Whereas we do contract with health plans, and we do get reimbursement through health plans and through the federal government and state. Whether it's through Medi-Cal or Medicare, whether it's through a commercial health plan or what have you. But what happens is our patients are able to get those services with limited to no cost.
Right.
Some of their health plans might have a small copay. That's not really our response. We were responsible for collecting that, but that's a part of their health plan, their agreement with their health plan. But we do offer sliding fee scale. So at any given point, if their inability to pay is there, then we'll reduce and or eliminate the cost of whatever copay and or out-of-pocket that might be there. We have patients who don't have coverage and don't qualify. They kind of fall in between the lines, so to speak. And for those patients, they're cash patients. But again, the sliding fee scale applies to them as well. So as an FQHC, one of the main tenets is that we're not really allowed to turn people away. Our job is to provide those services and find a means to do so. And the funding that we receive to do that is to a certain extent allocated towards being able to provide that to individuals who could otherwise not have that service.
And so in many cases, does that frequently manifest in a patient coming through the door, maybe thinking they don't have the resources to receive care and being enrolled in a program through you guys, right? So that you're able to recover some of the costs.
I'm sorry, for some reason it cut out.
No worries. I'm saying, does this result in often a patient coming through the front door, imagining that they're a non-paying patient because they're not enrolled in any program, and you guys being able to enroll them in a program that will then reimburse you for services or enrolling them in your network?
Yeah, so I would probably say probably about 85% of the people who walk through our door were able to find some sort of program that they're eligible for.
They just didn't know.
They just didn't know, or they didn't pursue, or they didn't have a reason. The funny thing about healthcare is it is a sales job to a certain extent, because people, while they care about their health, are not all as motivated as you would imagine to actually go out and take care of themselves. So we do a lot of convincing and calls and sales on trying to get people in through the door to take care of themselves and get their medications updated, or check their blood levels and that kind of thing. So it's an interesting process, but those folks don't end up coming in until they have to.
Right.
And then that's when we kind of discover, hey, you're eligible for this, this, and that. Let's put it together and create something for you. So.
Yeah, it sounds like that's at least half the battle.
Yeah, it really is.
Getting folks, and that is part of the FQHC mandate, right? Is to get folks basically in the system who aren't.
Absolutely, yeah. I mean, that's one of the goals that we're responsible for to the federal government.
So beyond the telemedicine piece, how has COVID, impacted service delivery to clients? Are you seeing COVID patients? Are you doing testing?
Yeah.
In terms of the actual practitioner of care, in terms
Sure.
of PPE, just in what those encounters, in-person encounters look like, or even just like the waiting room, like how do you,
Sure. So, we talked about the remote visits, which was a big transition for us. And as some of you may know, we're not currently practicing in our dental suites or our optometry suites because of the fact of the intimacy in terms of the interaction that happens with dentistry and optometry and how close you might get to the patient. So those have been closed down since the get-go, and we haven't been able to start those up, but hopefully, God willing, we'll be able to do that soon. But yeah, we are seeing COVID patients. We were seeing them from the start. As you do these screenings, you do come across what we'll call persons under investigation. PUIs is the technical term that's used in healthcare for those folks that could potentially be someone who's a carrier of COVID-19. And we had to pivot quite a few times to kind of work it out. I mean, things changed rapidly and guidelines changed rapidly. And as everybody's probably aware, the supply on protective equipment was quite low and or non-existent. So how do you do that with limited use on PPE and how do you make it work? So we were able to essentially isolate those patients to our 6th Street Clinic site, which is the one across the street from the temple. Because of the space that we have available there, we were able to kind of isolate and contain individuals that we thought could potentially carry COVID-19 in one area of the clinic. And we had to establish entrance and exit routes that were aside from the public entrance and exits. We had, mobilization teams, so key individuals who would essentially take care of these patients every single time they came in to limit exposure across all of our staff. And then, of course, we had to establish what we call a point of entry screening station, POE station, where you do kind of the temperature check, screening questions, and so forth before anybody can actually walk in further past the elevator banks. So a lot of shifts were made in response to this, but we are doing testing. We have been doing testing. Recently, we've been increasing that testing because we've had access to the test kits. So having access to those test kits was initially a challenge, but we've been getting more of those. So we've tripled our testing over the past 2 weeks, and we're currently in the process of looking at essentially doing community testing. So large scale community testing, potentially drive through, walk up. It's in the works. We're discussing how that might look, where that might take place, and so forth. But that would probably be the next step for us in regards to fighting the pandemic. So we think it's important to do as the most scientists will support. Community testing is an important part of getting your hands around this, and so we want to do our part for that.
So beyond the testing piece, are you seeing different areas of need or different areas of care that patients are coming in for beyond testing as a result of this?
Yeah, a lot of the additional need that comes up right now is social service related. So you're thinking things like food insecurity, you're seeing things like financial issues, employment issues. So mental health has increased. People have come in for mental health services a little bit more so than they have in the past. And then our enrollment team, who does outreach and education, has been also doing much more of the social services. And that's from our perspective, is really just coordinating the patient to various services that they may or may not need in order to kind of help them do that. We also have done a few food giveaway events with various partners throughout Los Angeles. And we've done that in our back parking lot. We've kind of reallocated our van for a while to kind of deliver food to seniors in Koreatown. So, things like that in regards to how we can contribute to that side of things. But the social determinants of health is what the kind of key term that people use in healthcare. And that's been a little bit more on the rise during this process. So aside from that, to be quite honest, it's been, the usual menu of issues that we've been seeing in the patients and so forth. But those social issues have become a little bit more prominent.
Makes sense. And you spoke about the enrollment team kind of pivoting a little bit to do more social service, kind of wraparound triage type stuff. I also wonder on the enrollment side, are you seeing, like, is the profile or the picture of the patient who's enrolling, has it changed or expanded at all? Like I'm imagining or wondering, somebody just with unemployment, creeping up every week, somebody who 6 months ago had a Blue Shield PPO plan and, wasn't coming to CARE, let's say, right? Now doesn't have that job and maybe doesn't have COBRA or whatever, and suddenly finds themselves, looking at a different avenue in the healthcare space.
Yeah, interestingly, we have seen an increase. We certainly have seen an increase in new patients, although it hasn't been, a mad rush to the door, so to speak. But we have seen an increase in new patients. We've also seen a lot more of our existing patients come in. So last year, by the end of the year, we had served, I think it was somewhere a little bit over 12,000 unique patients throughout the entirety of the year. Whereas right now, 6 months in, we're close to about 9,000. And that's because I think most of the patients that we currently have that make care of their medical home are a little bit more proactive about coming in or being seen. So we're seeing a lot of the same patients. We are seeing some new patients. As far as demographics go, interestingly, that hasn't really changed a whole lot. We haven't seen too much of a shift in that respect. So it's been kind of the same demographic makeup as far as that's concerned. But
I wonder if some of it, and we've talked about this in a few of our conversations over the past few months, but that maybe that the real economic toll of this on folks has yet to come, right? And it's months from now when folks really, COBRA runs out or unemployment gets worse.
Sure.
So the virus, maybe is going to peak when it peaks, but that the financial and economic peak has yet to come for the pain.
From what I can gather thus far, things don't. This was probably more just my own personal opinion, to be quite honest, but things haven't improved as far as I can see. Yes, I think that the response in the state was actually a very strong response in terms of unemployment benefits, in terms of access and that type of thing. I'm actually much more impressed, and they surpassed my expectation. That being said, there's going to be a limit to that, I think. And I think you're correct in that, these things are going to happen in waves, as we're seeing right now, just with kind of the increase in COVID cases, right? Things are going to happen in waves, and I think the financial and social aspects of those will also happen the same way. We're functioning and moving forward as though we will be under these circumstances for the next year or two. Even though that may not be the case, and likely won't be the case. I don't know that it's going to last for 2 years, but we are acting as if that is going to be the case, so that we don't let our guard down, so to speak. But we do fully expect to be dealing with this at least through the end of this year, if not into next year. So from a realistic standpoint, on our perspective. Now, I could be wrong. I'm not an epidemiologist. As you said earlier, I'm not a politician, epidemiologist,
nor am doctor, but I think if I were a betting man, I think you're more likely right than wrong on that one. You spoke about demographics not, markedly changing maybe yet. Can you talk a little bit about, just in general, what the demographic of kind of CARE's patient population is? Because I know it's incredibly diverse.
Yeah, we are quite diverse, although the bulk of our patients, about 55 to 60% of our patients, are Korean American. And that's a big part of that has to do with the fact that when we started this organization, the specific purpose of KHEIR was to provide coordination of services for recently immigrated Korean Americans. So people who had just come out to America from Korea, helping them get connected to things like healthcare, employment, citizenship, and that type of thing. Over the years, it kind of evolved into becoming a medical clinic, and that's what we do at this point, and the main thing that we do. But I would say about 55 to 60% of our patients are Korean. We are seeing an increase in East Asian patients. So a few years ago, we kind of tapped into the Bengali community because little Bangladesh is not very far off from Koreatown. And we saw kind of a slow but steady growth in that population. And about, I want to say, a year and a half ago, we hired a Thai-speaking physician, and we've seen kind of an exponential growth in our Thai-speaking patients. So the East Asian group is growing somewhat rapidly over the past year or so. And then, of course, I'd say about 20 to 25% of our patients are Latino, Spanish-speaking folks. And then a small portion, maybe about 10%, are Caucasian, African American. So kind of gives you a sense of our breakdown.
It's, diverse to say the least.
It is. I mean, we have our pockets, but yeah, we certainly do have a pretty diverse group, and folks are coming from all over the place. So I can't remember what the count was, but it's, double digits in regards to the amount of zip codes that we're serving. And part of that is because of our language capacity. So people will travel the distance in order to be able to see a clinician or a practitioner who speaks their language and kind of understands their culture. And
so just, it doesn't have to be the exact number, but how many different languages are you able to support, with a native speaking practitioner? I shouldn't say native speaking practitioner. That's irrelevant, actually. But
well, we have also interpreters on staff and folks like that. But I kind of count it out for you in my head real quick here. Thai, English. Directly, I would say probably about like 7 or 8 languages.
Oh, that's a lot.
Yeah. Now that's not including other folks that we have on staff, like myself, for example. I speak Farsi. We don't have any patients who speak the language, but if we had, we'd be able to do that. But that's mainly just focusing on the patients that we're currently seeing. So
makes sense.
Yeah.
So what are and aside from money, I always have to throw that caveat out there because money's always a challenge for everyone. But aside from obvious financial constraints, what are the biggest challenges that you think you guys either have continue to face or maybe even see coming down the pike?
Yeah, I think the obvious answer to that is the PPE, the personal protective equipment. That's been a huge challenge for us, and it's quite limiting in regards to what we can or can't do for our patients. We have seen it loosen up a little bit, which is nice. I don't think we're necessarily in full-on panic mode, but we haven't seen improvements to the extent that we would need in order to really kind of move things along back to normal operations. So that's I consider that to be an ongoing issue, and I think that we'll probably continue to have problems with that throughout this entire pandemic. So that's been a big challenge for us. Interestingly, the fact that the social distancing measures has been kind of a challenge as well. And I don't say challenge in the sense that it's a problem, because social distancing is a solution, but just the creativity that has to come from figuring out how to coordinate your space differently, and how to limit individuals, and how to expand your waiting rooms, and what are you going to do in the long term? Because right now you still have a certain faction of the population who's willing to stay home. But at some point, people are going to get more and more stir crazy, and they're going to want to have excuses to get out of the house. And seeing your healthcare practitioner has been from the get-go justifiable reason to leave your home. And so we expect to continue to see more and more face-to-face. So how do you do that, and how do you deal with that in the long run? Because space will be an issue. You can't fit 20 people in your waiting room anymore. Our waiting room was, at the clinic right across the temple. I mean, we were able to fit, I think, something like 26 patients there. And right now, I think we have a limit of maybe 10, you know. So how do you deal with that? And so that's been an interesting challenge as well.
Which then, right, creates a whole chain reaction of, if you have, if your waiting room is at 40% capacity, then what does that do for appointments, right? If you can't, because you're not, it's just like a restaurant, right? If the restaurant's operating at 25% capacity, like that's serving less diners per day, and there's the economic realities of that.
Yeah.
Right. And also, I just imagine the certain aspects of patient care necessitate, we were talking about dental and vision, necessitate a practitioner being not socially distant from the patient.
Yeah.
Right? You're not gonna clean somebody's teeth, from 6 feet away, right? Or do a glaucoma screening from 6 feet away, or listen to someone's lungs with a 6-foot long stethoscope. I don't know, maybe, but right.
Although that would be an interesting invention to think about in the time of COVID-19.
You can have it. You can have that. You can have that innovation. On that note, for our folks who are with us on Zoom versus Facebook, what are your questions for Navid, who's been so generous with his time this morning? Go ahead, Merle.
Okay, I have a friend who here works for Abrazo, which is a big medical group. I don't know if they're just here all over the country, and she works in the call center, making appointments and all that. And for a while, they hardly had any calls. People just weren't calling, probably with the fear that they're not going to go to the doctor or they're not going to let them in. And then people started calling, and business became more and more. And a lot of people are complaining about the telemed, that they don't feel like they're getting, and do people in your practice, in your group, are they using telemed? I mean, some hospitals here won't even, I was supposed to have it for a program for a diabetes consultation with one of the hospitals, and the hospital won't even let this group do telemed. So I'm just curious as to people's reaction to it, and how if people are using it, and does it help?
Sure. Yeah, so we are doing telemed. So yeah, we're either doing it through video conference platforms, or we're doing it on the phone. Initially, there wasn't a lot of pushback, and we also weren't giving patients the option to do otherwise. So we identified specific visit types that we can do via remote visits. And we didn't give them the option, because initially it was shelter at home, and everybody stay where you're at and stop moving around. So we wanted to support that. As things have kind of loosened up a little bit, we've started to push the remote visits. But if a patient is pushing back and wants to come in face to face, we're not necessarily stopping them. We are getting to a point where we might have to start looking at how to address that, because the number of face to face is increasing. But patients haven't necessarily complained about it, more so than really just, it seems like it could be kind of a combination of, I just want to get out of my house. I need to get moving. I'm getting stir crazy. But I think that our particular population also values kind of the old school.
You've got mail.
Nope, you've got mail. The old school.
Speaking of old school.
Yeah, right.
You don't know how to turn that off.
Interaction with the clinician, right, the physician, and really going and having that face-to-face. They often feel like they're not going to get the type of service that they need, or that the doctor might miss something if we're doing it via phone or via video. Whereas, there are certain cases when that might be true, if I'm looking at a rash, or, at a wound or something to that effect. But there are many cases in which they can do the job just as well remotely. And to be quite honest, there's quite a few benefits to it, in terms of removing some of the barriers of transportation. We have patients who might spend 2.5 hours just taking buses to get here, right? And then they have to spend another 2 hours at our site, and then another 2.5 hours to get back to work, or whatever it is. I mean, their entire day is essentially gone. And these are individuals who can use the employment time and making that money. So being able for them to just kind of step away from work for 15, 20 minutes, get on a phone call and have that visit, get their needs addressed is quite a big, in my opinion anyways, a big move in the right direction. But some patients still want to come in, so.
And Navid, just to jump in, I think you're absolutely right. And I think that as this goes along, for longer than any of us would probably like it to, I think not just with obviously medicine, but folks' comfort with this kind of medium increases, right?
Yeah.
And probably most of us here, I hated Zoom meetings. I still do, but I hated Zoom meetings, 5 months ago and would avoid them. And I was the guy that always called it on my phone because I didn't want to be, doing this, right? And now it's just what I do all day, right? So I think that this is just becoming normative very quickly. And I think that will extend to telemedicine. I think it will extend to, your accountant, your rabbi, whatever it is. I would have never done a funeral intake or something, or a wedding meeting with a couple on Zoom, much less led a service on Zoom, right? 6 months ago. And now it's what we do.
Yeah.
Gail, I see your hand up. I'll unmute you. Here, Gail, I think I can unmute you. All right. There we go.
It wasn't working. Thank you for your help. I actually have two questions. I don't know if the second one's in the right domain, but my first question is about what happens in that restricted COVID area of care when somebody is really sick. Are you hospitalizing people? Is there a problem in having beds? Has there been a problem? What kind of follow-up is there for the really sick patients?
Yeah, so as far as what's happening there, are the staff that goes into that room, they're fully clothed in personal protective equipment. So, and when you leave that room, before leaving, you have to kind of disrobe. And then when you go back in, you got to put in a whole new set and so forth. And so that's kind of the challenge with the equipment that we're not getting our hands on. But, we have had a few cases that needed to be hospitalized. Luckily, we haven't seen too many. I want to say maybe about 3 individuals who we had to hospitalize directly from our clinic when they came in. And 1 individual who came in, symptoms got worse and was hospitalized. And we were informed by the patient's family that they had been hospitalized. Now, luckily, all of them have recovered. So we're very grateful for that. But, we've seen various levels of symptoms. Some people coming in with just a cough and a slight temperature, and that's the extent of it. And then we've seen individuals who've come in with, severe symptoms. In either of those cases, we kind of follow the same protocol in regards to what's actually happening in the room. But typically what we would do is we would do a phone screening and determine at the point of the phone screening whether or not this person should come in. And then at that point, we would either decide they should come in and get tested, or they should come in and see a provider. If they're coming in just to get tested, then we would send one of our assistants down to the parking lot to do a in-the-car swab, rather than having them come into the clinic and potentially expose. But there have been cases where the doctor said, look, I think I need to see this patient, have them come in. And so we go through our protocols and process of doing that. And then at that point, we determine what the next steps are. And some of those next steps could be, I'm going to hospitalize you. But more often than not, it's, let's test you. Here's, some prescriptions that might help with the cough and so forth. Go home, stay home, and we're going to check in with you in 3 days and see where you're at. So.
Are you doing the self swab? Is that the kind of testing you have?
So yeah, we've been doing we've been doing the nasal and the oral. So those are the kinds of tests that we've been doing.
Do you see a difference in terms of how accurate they are?
Not at this point. We just started doing the oral swabs 2 weeks ago. as we've tried to ramp up the testing. And thus far, we haven't had any issues, but it may be too early to tell. If the oral swab is done correctly, it's just as accurate as the nasal swab. So it's just the issue that there's more room for error with the oral swab, and that's what we've seen in the past. So, but let's see how it goes. For now, we've been doing okay.
Thank you.
Absolutely, thank you.
Anybody else? All right, well, I'm conscious of everyone's time and our time this morning, but Navid, thank you. Thank you for being so generous with yours. Absolutely. And for a really, really thoughtful and wonderful conversation.
Yeah, I appreciate
it. You know, I look forward to lunch at Cassell's when such things are permitted again.
And me too, brother. I got to tell you.
All right. Well, thank you, everybody. A quick plug for next week. Next week, my friend Steve Kang, who is the Director of External Affairs for KYCC for the Koreatown Youth and Community Center, KHEIR's neighbor across the street, is going to be with us talking about all the community work that they've been doing for the families that they serve, and how that's shifted a little bit in the midst of the pandemic. So don't miss next week, and tell your friends. Yes, Merle.
I do have one quick question. Do you test through blood work?
We haven't been doing that, no.
Okay, I was just curious.
Yeah. There's various reasons for it, but no, we haven't done that. If you want, I can expand on it, but it looks like we might be out of time. So.
I mean, I have to go once a month for blood work anyway for my diabetes.
Okay.
So my doctor is testing as many patients as he can through their routine blood work.
Okay.
And it seems to be pretty effective.
Yeah. Good. Well, thank you, Rabbi. We appreciate your invitation, and thank you guys so much for letting me join your meeting today. This was a wonderful
conversation.
Thank you so much.
All right. Take care, everybody. Have a great day.
All right.